The Knowledgeable Provider podcast is intended primarily to entertain, also to inform, but it is not a substitute for actual medical training and should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, please make an appointment to see your own knowledgeable medical provider. The opinions expressed by me and anyone else who happens to appear on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than the lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. Look, this is all for fun, okay? Don't sue me. All right, on with the show. Hey there. Welcome to the Knowledgeable Provider podcast. I'm Jody Marks. I want to talk about bias in medicine today. Of course, bias just means that we have preconceived notions, you might call it prejudices, within us that end up affecting how we interact with other people and how we interact with the world. It's really fascinating to me how something so deep in our subconscious can bubble up to the surface and end up having pretty significant consequences for how we deal with other people. And for us as medical providers, of course, that can even end up having consequences for the patients that we are taking care of. So it's very important for us to be aware of our own biases. Maybe it's biases. I'm not sure. I'm going to say biases. We need to be aware of those in ourselves so that we make sure they're not impacting the decisions that we're making for other people, for our patients. The Smithsonian has a traveling exhibit. It's called The Bias Inside Us. It's currently in our city here in Huntsville. I went and saw it a couple of weeks ago. Very, very interesting, insightful. If you ever get a chance to go check that out, you should definitely do it. And I'll put a link to their website in the show notes. Probably the first thing that comes to mind when we think about bias is racial bias. But of course, bias really can be based on anything. It's not just a racial situation. In medical settings, talking to patients, maybe some things that we would have a bias against would be someone's gender, sexuality, someone's criminal history, how someone reacts to stress or trauma. The classic example would be, oh, that person's not hysterical enough, or that person's way too calm for the situation. But we know that people respond to stress and trauma and grief very differently. Someone's personal hygiene, of course, when you're close to someone like we are when we're examining people, talking to people, we become very aware of their personal hygiene and how they smell and that sort of thing. The clothing that somebody's wearing, it's sad to say, but how much money somebody has or whether or not they have insurance in our United States medical system, unfortunately, that can be a very prevalent factor that we have to think about for one reason or another. How severe someone's condition is. You know, a person's idea of how sick they are may not be the same as our idea of how sick they are. Really, if you think about it, there's some bias involved in triaging people. I would say that that is not always based solely on medical facts and vital signs and that sort of thing. Sometimes it's just about our we call it a general impression. Sometimes it's just about the sense we get from talking to somebody, or you just eyeball them and think, maybe there's something wrong here, or there's not anything wrong here. How a person tolerates pain might be another thing. We know that everyone's reaction to pain is different, and what one person considers very severe, another person might not react to at all. The language somebody uses, or their accent, or their dialect, how needy a person is. You know, how much a patient hits that dadgum call light can definitely affect how you feel about that person as the 12-hour shift wears on. Gifts to the staff. Whenever I have a family member in the hospital, I always take a big box of donuts to the nurse's station, because I remember when patients would do that for us in the ICU. It was just such a nice gesture. Not that we would treat anyone any differently because they brought us something like that. However, I like to think that when the medical staff hears my family's room number, they don't automatically think, oh God, I don't want to go in there. I want them to think, oh, we like them. They're so nice. Did you know they brought us donuts? One dangerous source of bias is information we get from other people. So maybe the chief complaint that we read, or a report that we get from someone else, either at change of shift or transfer of care or whatever. When you get that information, you're already seeing information that's been filtered through somebody else's biases. So if the offgoing nurse tells you, oh, this patient's miserable or this family's terrible, you're already going into that with your own bias based on somebody else's bias, or with the chief complaint. Whoever triages the patient puts in, or even whoever schedules the patient puts in whatever, urinary tract infection. Well, now I'm going into that room already thinking I'm seeing somebody with a urinary tract infection. So that's introducing an element of bias. And that actually has a name. It's called anchoring bias. That means that we, quote unquote, anchor on the very first thing that we hear or think. And then the whole rest of our interaction is colored by that bias that we've already formed. Secondary to that is what's called confirmation bias. So once we have something in our mind, we start looking for evidence to support that theory, and we also might ignore evidence that refutes that theory. So when we're trying to diagnose someone, you can see if you're already coming in with a preconceived idea of what they have, and then you start looking for things that confirm that, you may not ever really start with an open mind and just get the patient's story from the beginning. So we have to be super careful about that. I saw this happen very clearly one time with a student I was precepting. I don't remember what the patient was there for. I'm going to say it was a urinary tract infection, UTI. It might have been something else, but we had that information before we went in. And so we were in there together. The student was doing all the talking. And it was obvious that she had already kind of decided, oh, you have a urinary tract infection. And so she starts asking questions, looking for information that confirmed that. And somewhere in the middle of the interview, the patient throws in this, oh, and I'm also having some trouble breathing. And in my mind, I'm thinking, wait, skirt, that doesn't fit with urinary tract infection. Let's go back to that. The student just rolled right on past it. And so I stopped the student. I stopped the train. I said, hey, let's go back and talk about this. And so afterward, after we had seen the patient, we talked about anchoring bias, confirmation bias. And it was really interesting to see that happen in real time. When I worked on the ambulance as a paramedic, the dispatch information could be a significant source of bias. When you're out in the ambulance being sent to the scene of something, you're not talking to the patient or the whoever called, right? It's the dispatcher talking to them. And so all the information that we get updated with is filtering through the dispatcher. And in a lot of cases, it's also filtering through whoever is calling who's not actually the patient. You remember the whole telephone game where you relay messages from person to person, and it's very interesting to see how the message has changed by the end of the line after it's been passed through all those people. That's definitely something that happens in EMS. And again, it's kind of dangerous to go into a situation thinking it's going to be one thing. You've already got your brain set on that, and then many, many times in EMS, it'll turn into something different. So we always have to keep our minds open, be aware of any bias that is creeping in, whether it's from us or from other people that might be involved. One of the things I learned from that Smithsonian bias exhibit was that musicians, like classical musicians auditioning for orchestra kind of situations, they will actually audition blind. They'll sit on the stage, but they're behind a curtain. So the people who are listening to them are only hearing them playing. They're not seeing what race they are, what gender they are. And it turns out that when they started doing that, a lot more women and people of color, minorities, started getting hired as musicians. Imagine that. So there was obviously some bias involved in the people who were evaluating the musicians. And sometimes I wonder what it would be like if we could talk to patients like that, either behind the curtain or even like reading transcripts of what they would say. It'd be interesting to know how our decisions might be different if we didn't have all these other factors getting in the way of just what they're saying, what they're telling us. And these days, really, maybe telehealth is sort of a version of that. You know, if I'm just talking to somebody on the phone, of course, with my patients, I know who they are. I already have that relationship with them. So there's a lot of information that I know just from seeing them previously. But if you're just talking to somebody on the phone, you know, you're not seeing what they're wearing. You're not seeing what they look like or how put together they are. You're not smelling them. So there's a lot of information you're not getting that might be something that could lead to you behaving based on some kind of bias. I don't know if there's any studies about that, but that would be an interesting thing to look at. One way I've seen bias manifest in medical folks is in code switching. Code switching means that you change the way that you communicate based on the person you're talking to, whether that's changing your language or dialect, expressions you use, body language, whatever. The other night we were watching this reality show where they follow around the first responders down in New Orleans. And man, if you want to see an example of some code switching, just watch how those folks talk to each other and to the camera, and then how they talk to the patients they're caring for. To me, it seemed like such a stark contrast. And maybe they were just trying to speak more formally for the camera, for the TV crews, and then speaking more like how they would naturally speak when they were out in the field on calls. I don't know. And I don't know. Obviously, I don't really have any experience with this. But I feel like if I was a person of color and somebody was doing that to me, that would be offensive to me. It seems very patronizing. And maybe people are making a genuine attempt to relate to someone else when they're doing that. Maybe it's some kind of attempt to feel like they're a quote unquote good white person and not paying attention to the race issue. I'm going to guess that it's just somebody who's not comfortable speaking to people of other races, and that's just how it manifests with them. But I don't know. And the question is, are we really communicating effectively with somebody when we're changing the way we communicate? I want to switch gears now and talk more about systemic bias. Of course, I'm going to focus on systemic racial bias in medicine, but you see this everywhere. And the more you become conscious of it, the more you start looking for it, the more you see it. Just this past week, I was looking on one of the local TV stations' website. And so there's all these stories on there, people who have gotten in trouble for whatever. And for the most part, they put these people's mugshots on there. So I'm scrolling down, looking through all this stuff, and this one picture jumps out at me. And it's this black guy that's looking incredibly menacing. He's holding like 3 guns in his hand, pointing them right at the camera. The story associated with this is about a 14-year-old who has allegedly committed these crimes and is going to be charged as an adult. So I saw this picture, I stopped, I read the headline, and I thought, this is crazy. These are pictures that they obviously pulled off this kid's social media accounts, and they're presented in a way where you look at the picture, read half of the headline, and you're already thinking, oh, obviously this person has done something wrong. Look at this. But what it is a picture of a child, a minor, who has not been convicted of anything, as far as I can tell. And it's just such a terrible, terrible way to present something like that. So I keep scrolling. The very same day, there's a story about this guy that was a gymnastics coach and was molesting all these girls who just got sentenced to prison. This is an adult who's been convicted of a horrible crime against children. And the picture they have of him is just this goofy, shot of him standing in some random room with this half smile on his face. If you didn't know who it was or didn't know the story associated with it, you go, look at this goofy dude. It's somebody's dad, and he's a white guy. And it's just such a totally different standard. It's such a stark contrast that you go, this is absurd. How could a professional news organization be so blind about how they're presenting this? The answer to me is they're not blind about it at all. It's very intentional. And once you start thinking about that, once you start looking for those things, you start seeing it more and more and more. It's out there. It's out there. It's alive and well. So talking about medicine and some ways that systemic bias shows up in medicine, there's a big story going on lately about the race-based GFR calculations. They used to use race in those calculations in a way that actually overestimated kidney function for Black patients. And so that ultimately resulted in people who needed kidney transplants being ranked on the list based on their kidney function, which was biased based on their race. And so you ended up having these Black folks that are further back on the kidney transplant list than they really should have been. And I couldn't find a statistic about this anywhere, but how many people died waiting for kidneys or had to suffer on dialysis for longer that might have otherwise gotten them? And so this is being corrected, and the transplant centers are actually now having to go back and redo the list, move people around on the transplant list based on more accurate calculations of their kidney function. And so this is obviously the right thing to do. I'm glad they're doing it. But think about being one of the people already on the list and now being moved back. So that's a really good example of how when racial bias creeps into something that important, it affects everyone. It sucks for everyone. Of course, race is also still a factor in the prescribing guidelines for blood pressure medication. There's still this idea that we're supposed to start with thiazides and calcium channel blockers specifically for Black patients. And do we really think that that makes any sense? Out of one side of our mouths, we say, oh, race is just a social construct. There's no biological difference in people of different races. But here we are still doing a thing differently based on somebody's skin color. I did a clinical rotation in family practice with a Black physician, and she told me straight up, white physicians think that Black people's blood pressure cannot be controlled, and they give up trying. She said, of course you can control it. Just like everyone else, you just have to keep trying, find the right medicines. And of course, yeah, why would you give up? Why wouldn't you keep trying just like you would with anybody else? I thought that was a pretty eye-opening thing for her to say, because obviously that's either based on her own experience or the experience of her patients. And that's a clear example of racial bias creeping in and affecting individual treatment choices. There's a good in-depth article about how we got to this place where we have different instructions for Black and white patients, specifically with this issue with the thiazides and calcium channel blockers. It's in the Journal of the American Board of Family Medicine by Holt et al. It was published last year. I'll put a link to that in the show notes if you want to check it out. I was curious about whether this only happens in the United States or whether it's a worldwide thing. I had trouble finding a lot of information about that. I did find a source, which is from the Journal of Human Hypertension, September 21 by Gopal et al., that says that South African and other international guidelines don't have anything about race and blood pressure involved in that. That article was from a British source, and apparently they had the same kind of race-based recommendation that we do here in the United States. Looking at the COVID pandemic, it's been pretty well publicized that minorities had ended up having worse outcomes and were more affected by the COVID pandemic. This is from the Kaiser Family Foundation. I'm just going to read this verbatim. Racial disparities in COVID-19 cases and deaths have widened and narrowed over the course of the pandemic, but when data are adjusted to account for differences in age by race and ethnicity, they show that American Indian and Alaska Natives, Black and Hispanic people have had higher rates of infection and death than white people over most of the course of the pandemic. So that's pretty unambiguous. We just had a 3-year-long case study in whether or not racial disparity in medicine exists during something like a pandemic, and we see that it does. There was a big document about this called Unequal Treatment that was published back in 2003, and it was this huge, in-depth look at racial disparity in medicine. If I've ever heard of this before, I don't remember it. If I'd ever heard of this before I was researching for this episode, I don't remember it. And obviously that was 20 years ago. So are things any better now? Are we doing any better now? I don't know. I'll put a link to that study in the show notes. I don't know if you'd call it a study or an essay or a book, but the whole text is available for free from NIH. So I'll put that link in the show notes. The New England Journal of Medicine runs a lot of really good articles about racial disparities in medicine. In the October 27th issue, 2022, there's a study by Garcia et al. That reports that Black and Hispanic people were less likely to receive bystander CPR. There's a really good article in the February 16th issue from this year, 2023, by Dr. Sarah Whetstone. She's the program director of the Obstetrics and Gynecology residency at the University of California, San Francisco School of Medicine. And she writes a little bit about her own challenges as a Black physician, in addition to being in charge of this program and trying to train people of color in the culture of medicine that still has so much bias against them. And I'll tell you, as somebody who grew up in the South, San Francisco is thought of as just the most liberal place, this bastion of left-wing thought. And so to hear that even there they face these kinds of disparities and discrimination, is so disheartening. It's so sad. Another article in the March 2nd, 2023 issue by Dr. Orlando Curtin and Dr. Selwyn Rogers tells a story of them, who are both Black surgeons, going to a big conference of the American College of Surgeons. And they both separately had experiences of their own colleagues mistaking them for, one of them got mistaken for the valet, and the other one was mistaken for like the tech, the AV guy that was coming to set up a room for a talk. And these are their own colleagues. They're walking around with, you know how it is at a conference, you got a lanyard and a badge identifying yourself as a participant. And still, these very accomplished surgeons were facing this kind of derogatory treatment from their own colleagues. And it's so hard, impossible for me really to understand what it must be like to face that kind of thing. Working in medicine or training to work in medicine, being a student is hard enough without facing that kind of discrimination. And I think it's very important for us as white people to realize and recognize and acknowledge that our colleagues are facing that sort of thing, and also to acknowledge the white privilege that is us not knowing what that feels like. One thing I hear from time to time is patients complaining about seeing foreign doctors, and I always wonder how much of that is a valid complaint about not being able to communicate with the doctor, not knowing what they're saying, or just some racial bias creeping in there. I guess if you honestly can't understand what somebody's saying because of their accent, maybe that's a legitimate gripe, but I'm guessing it's mostly just bias. I didn't know this for a long time, but if a physician trains in another country and then wants to come here and practice, they don't just roll up in here and fill out some paperwork and get their license transferred or whatever like you would as a nurse going from state to state. They have to go back through the whole thing as if they were a brand new medical student. They have to take all the tests again, go through all the stuff to get certified again here in the United States. And I guess you could look at that as a good thing because we want to make sure that our physicians know what they're doing and have the appropriate training. But when you think about somebody who is tough enough and resilient enough and smart enough to go through all of that just to practice medicine here, I mean, that's a person I want to see. And it just breaks my heart when you see people dismissing those physicians as foreign doctors, not even realizing everything that they had to go through just to be here if they weren't trained here in the United States. So those are all my thoughts on bias. That's everything I had put together that I wanted to say. I encourage you to think about this in your own practice, in your own work situation. Don't be afraid to examine your own bias, acknowledge it, and then think about what you can do to mitigate it. I'll leave a link in the show notes to the Harvard Implicit Association test. This is a site that has all kinds of different tests that you can take to assess your own bias. The only one I've actually done is based on race, but there's a bunch of them. There's one for weight bias, there are ones for gender, skin tone, age, disability, religion, weapons versus harmless objects, all kinds of little tests that you can go through. Some people I've showed this to have kind of argued about the methodology or the validity of the studies, and that's fine, but I think there is probably a lot of truth at the heart of it, and so I encourage you to go take some of those and just be open-minded and see if anything comes up that you wouldn't have expected in yourself. I'm a big advocate for listening. There are times, of course, when we're busy and overwhelmed, and sometimes the situation does dictate that we really take control and get things done quickly and move it along. But most of the time, if we're honest, we really could just shut up and listen to the patients for a while. I know when I've been a patient myself in different scenarios, I felt like I couldn't get through a sentence, being rushed along by people who are always in a hurry, always trying to get through with what they're doing. And obviously, if we jump to conclusions without hearing the patient out, we might miss some key information that would change our decision-making, our thinking, and also interrupting somebody's just poor form, right? It makes the patient feel uncared for, unimportant, unheard, etc. But all that said, some things do come up so often that you kind of start to get a sense of where people are going as soon as they go down a line of thinking. And in the back of my head, sometimes I do find myself thinking, I could really save us both a lot of time if I just go ahead and answer the question that you're about to take several minutes to ask me. So here's a silly little fantasy segment I call the Preemptive Strike. I hope you enjoy this. All right. Let's see what the next patient's here for. Weight loss.
November Oscar Bravo Whiskey. Jeff Oscar Bravo correcting and
commencing preemptive strike.
Hey there, what can I do for you today?
I'm just super frustrated that I can't lose any weight.
Target acquired. I've got tone. Box 2.
I'm sorry, your insurance probably won't cover the shots unless you have diabetes.
That's a kill.
Don't be afraid to ask questions. Don't be afraid to ask for help when you need it. I do that every day. Asking for help isn't a sign of weakness, it's a sign of strength. Because it shows you have the courage to admit when you don't know something, and that then allows you to learn something new.
This week I learned that metformin can have a direct effect on vitamin B12 levels. According to an article by David Bell in the Diabetes, Obesity, and Metabolism Journal, the proposed mechanism of this is that the medication interferes with the binding of the complex of intrinsic factor in B12 to the receptor that it's supposed to hit, which is a calcium-dependent process. For patients with diabetes who are on metformin, it's actually recommended to check the B12 level once every year if they're already at risk for B12 deficiency for some reason, or if they've been on it for more than 4 years continuously. For people taking metformin for any other indication, it's recommended to check the B12 level every 2 to 3 years. All right, that does it for this episode of Knowledgeable Provider. I'm your host, Jody Marks. Thank you so much for listening. Don't forget to like or subscribe or follow and leave a nice 5-star review. And as always, stay safe, take care of yourself, and take care of your patients, in that order.